Well, welcome everybody to our Difficult Conversations series today. We are very happy to have with us Scott Mills of Signature Hospice and Healthcare. I think he's got a better title than that, and he'll share that with us. Scott has been working with us on different partnerships for quite a while, and I'm very excited to have him be our special guest today.
Yeah, thanks for having me. I'm with Signature, and I have my title really is more of the community outreach manager. I sort of really just try and help coordinate care and making sure we're taking care of the people that are needing the care. A lot of, I think, the hospice side of things, and why we're calling it that sort of awkward conversation, is that when people hear hospice, they think immediately that it's sort of end of life and that's it, we're done, put me on this thing, I'm in bed and let me die sort of thing. Well, it's not that, and I put it in a very negative way, but that's how I think a lot of people see it, compared to what the benefits that it can have. So hospice is really about aligning goals, what your perspective of life is at that point. It's about the care that we're giving. So it's aligning up where you're at in life. I put it in the perspective that we all are at a placement in life, and we all sadly have an expiration date. And when that expiration date happens, and how do we get from A to B, and what do we need to get from A to B? So the care of hospice is complete quality. The actual, when I'm talking to families, it's, are you aligned up with what hospice care means? So I'm going to go through the hard part. The hard piece of conversation that I tend to have is that we have to qualify for it, and the diagnosis is 6 months or less to live. And when we hear that, it's really hard to hear, 6 months or less to live. But we also don't know whether that's true or not. No one has a crystal ball, so we can't say, hey, that's exactly what's going to happen. Doctors are just going by diagnoses, from previous situations. But the qualification has to be a terminal qualification. And when we look at who qualifies for that, and should you go on hospice, that's where we come to that decision-making process. Typically, the perfect person to go onto hospice is someone who really is sitting there going, I do not want to go to hospital anymore. I do not want any treatment. I hate going to hospital. I hate going because I get in hospital for a day. They put me through all these tests and poking and prodding, and then they put me in a bed for 2 days, and then eventually I get back out and come home, and then another month goes by and I'm back in hospital doing the same thing, and I just don't want it. I don't want that. So that's a good time to look at hospice, because you're saying, I do not want treatment anymore. And that's what hospice you have to do, is you can't treat anything anymore, but you can look at your quality and comfort.
Right. It really affects your quality of life, when you're at that stage. And I've seen it many times working in long-term care with seniors. We all get to that point where enough is enough.
Yeah, enough is enough. And that's where we come down to, okay, we're here and we have an expiration date. So when we look at hospice and we get to that point where the story I'm telling you is not going in and out of the hospital, now we got to look at what's that quality of life and how does that look? And the goal for hospice is to just care for someone completely at home. They don't have to go anywhere. We have our team coming and looking after them, keeping them in the comfort of their own home or wherever or community that they're living in, and make it so that they start looking at that quality, and keeping, a lot of times we're doing pain control, so keeping that pain under control. Another thing is people say, well, now I can't go to hospital. What happens if I have something really happens to me? So that's another myth that people are coming across, which is, I can't go to hospital anymore. But you can go to hospital. It's just that, so if someone fell and knocked their head and they needed stitches, we get them to hospital. But the idea is to get them in and out. So they don't, we're telling the hospitalists that, they're on hospice. They don't need tests. We just need them in, stitch them up and get them home. Yeah. So hospital, we can still go there, but we obviously want to make sure that we can treat where we can. So like UTIs and things like that, we can treat at home, and most mild cases and things we can.
Hospice as a title, you're right, is kind of a bad catch-all for everything that actually can be offered, resources and services, different interventions. So
Yeah, it's hard because that's the one thing about, I mean, I have conversations constantly, and it's like, oh, I'm not in bed yet, I'm not dying yet, I'm not bedridden yet, and you don't have to. It's just catching the time early enough when someone's making that decision,
right,
so that they can benefit from that care.
right.
With the benefit, I mean, really, there's as we do care at home, we have a full care team. So you've got nursing, you've got bath aides, you've got medical social workers, you have chaplains available, and the chaplains are all to do spiritual needs. So it doesn't matter what religion you are, they're there to provide it. We have therapy, so you can get acupuncture, we can get massage, we can do music therapy, we can have pet therapy. So there's all sorts of, and then we have volunteer programs as well. So sometimes we have people that will sit and be with a person that is in that need. Signature itself does a program that's a non-profit that's called No One Dies Alone. So a lot of times we find that maybe in memory care where sadly people get forgotten about, and so we have volunteers that can come and sit and be with them, hold their hand, sing with them, and be a friend for that time that they need them. And that volunteer program is for anyone on hospice, so they don't have to be on a particular hospice. So there's lots of different things, benefits that someone can have. We went through qualification, so there has to be a diagnosis to do it. Also, when we get a diagnosis and that scaredness, well, I've only got 6 months to live. We do have people that graduate off it, and why they do that, it's I think sometimes it could be a miracle. I don't know, but some people do. They get to a point where they're on hospice. We have to keep every 3 months recertify them. And sometimes we have to kick them off because they're getting better. Also, if someone's on hospice and they've gone on hospice because the doctor said there's no more treatment, we can't do anything, we recommend you go on hospice and let's get that quality down for you. And then 3 months down the line, suddenly this miracle or the trials come out for a new treatment, someone can come off it. We can revoke hospice at any time, so they can go on to that treatment. And then if things need to be in the future, they can come back. So it's not final when someone goes on the hospice.
Yes.
Yeah, I look at it as treat every day as it's needed. So it's never final.
It's definitely a transition. Lots of things are changing and moving one way or the other. My mom actually had COPD and breast cancer and some other things, and she was on hospice, but she totally kind of plateaued and wasn't actively going one direction or the other, and they kind of switched her to palliative care. And it was kind of funny that yes, you can go, you're not always going to stay on hospice if you don't need it.
You're right. For example, a company like Signature, we have home health, and then we have palliative, and then we have hospice. So as you were saying, Dodie, you can go from one to the other and go backwards. So your hospice, you can go to palliative, and then the home health, and then you hopefully get yourself rehabilitated. Or you can go the other way. You're in home health, and then you go to palliative, and then you can go to hospice. But and back and forth if need be. Palliative is something I was also going to talk about, which is a program that's sort of not full blown. So some people think it's, I'm going to get a nurse every week coming to see me, and it's really not that intense. So when we have palliative, there's 2 people that will apply for that realistically, and that's one that's not ready for hospice, so they are still in that treatment stage and still can't let go of that. So we put them on a palliative so that we have our clinical staff still keeping an eye on them because things change, and normally that's happening every 6 weeks or so that someone's going by, but it gives the patient a system so that they can call if things are going on, and talk to somebody, and then we have nurses coming every 6 weeks to keep an eye and do that. But the other person that it would qualify for is someone who ideally wants to go on to hospice but isn't quite qualified yet, which is that diagnosis. So then we can put them on palliative while we're seeing things if things change a little bit.
In that particular case, somebody requesting that's not quite ready for hospice. Is that because they are ready to just be done, or is it just that their terminal diagnosis just isn't
ready? It's not.
Yeah.
Yeah. So the first scenario is someone's just, I'm doing cancer treatment, but I need that additional care. And then the second one, which I think you were asking a question, is a patient that needs hospice, but when our doctors are looking over it, it just doesn't quite qualify. They don't have enough diagnosis to qualify for hospice. So then palliative is that point where it might be that things might change in a month and then they become qualified. So it gives them some care in the meantime, so that we can keep an eye on them a little bit, and get that help to them. Really, you have to be in the right frame of mind to do hospice. This isn't for everybody, and there's no rush in anything. And when people have conversations about it, today I had a conversation with somebody, and it was purely that they just want more information on it. And sometimes there's this, what is treatment, and someone's maybe taking pills for cancer that the doctors basically prescribe to try and work with their cancer, but really there's no treatment left. And they're hanging on. When I'm having that, I have serious conversations. I'm not medical, so you need to be talking to your doctor about what treatment am I doing, and what is the outcome, and there is no rush. And sometimes we're having these conversations with families, and when we're there, they think they got to make a decision, and it's more about, look, I'm here to hold your hand right now so that you can make these decisions, but there's no rush. You just need to absorb the information, have some serious conversations, and then decide what fork in the road you're going to take. And that's what I think people are scared of as well, is having someone knocking on the door like myself to come in and talk to them, because they're afraid that someone's going to sign them up to something that they don't want to do. And I hate to say this, I was thought this morning, I don't know why, but it feels like I'm the Grim Reaper, knocking on the door, and it's not anything like that. I'm first on the scene typically, and that's to hold someone's hand, say, look, we've got you. We're gonna help you to get through some of this, and maybe it's not hospice. Maybe there's something else that's holding on for you. It's good, but it's definitely a decision that you don't want to make rashly.
And that's one of the reasons for this series and for having you here, is to get that information out to as many people before it's a crisis or before it's necessary, so folks can make better informed choices for proactive aging.
It's also about the family. So especially if we see someone in pain and things are deteriorating, and families don't know what to do, and it might be someone with dementia too, that there's a family that's making a decision, and they're holding on because they're scared of what hospice may bring, and rather than thinking what hospice really can bring. Once we get them comfortable, we're looking after not only the patient, so we're trying to get them comfortable, we're trying to give them the balance of that pain relief, and also being conscious to be able to have conversations, and working with the families too, because the families are going through a lot. I'm not going to lie, hospice is end of life treatment, end of life care, in most cases. So families do go through a lot of trauma to see their loved ones starting to die when they go into transition. The beauty of it is if we can keep it at home, especially nowadays with the COVID and everything,
Yep.
in their residence, the families have more access to them to be able to be with them. Also, we've got that support for the family members that are going through it, and especially when someone does pass, what happens then? How do you get looked after? So we're trying to look after the family with bereavement and things like that will be happening, and helping them get through that next year, which is normally the toughest part. There's a lot involved. It's not just the patient. The patient's obviously the center of it, but we've also got to understand how do we do our self-caring. And a lot of times we've got the person who's a caretaker is normally their spouse or their daughters or the sons, and then they get worn out, and then they forget to take care of themselves, and can get stressed out. And also hospice does another thing that is able to give family relief. So when someone's really in care, they can put them into a home or a community for 5 days. So especially if they're living at home, they can do that, and a family can get a break from the care side of it.
Now, isn't that covered by Medicare or?
That's also covered by Medicare for up to 5 days. And when I say it sounds like so bad, a family's just going to shove them somewhere so they can go away for a vacation, and it's really not that. It's more of the family get exhausted, and we see it, and they need to just take a break from the actual care side. So they're still going to go in and see dad or mum in the place, but they can catch up on all their sleep, and get start to do things that they need to, and then they get them back, and then they can carry on again. So it's sort of a way to help.
So you mentioned they can go somewhere for a respite stay, but you also can have someone come in for respite, can't you?
Yeah, you can. I mean, it'll pay, and that I think there's a bit of a grey area of where what's covered and what's not in that. With hospice, there's lots of things that people want, and when they're on hospice care and they have needs, we have those medical social workers, which a lot of work with what the family's going through, also resources. Sometimes it's placement, trying to figure out what we do. So I'm always saying just ask those questions when it comes up if there's a need. Sometimes we get, especially communities, asking about bath aids and how often can we have them, and what hospice will do is try and figure out what's the need, for and we know we don't want to do too much of that, but it's so. But if there's a need for something, ask for it, and the team will look into it. They might have the answer right there, but they'll look into things like you're asking about, could we do a respite stay and have someone come in and take care?
After hospice, I'm sure you suggest follow-up care or follow-up with the family. Maybe it's a grief support, or some kind of a support system like that.
Yeah, we let the families know. We do follow up with the family. They have that bereavement support, but for at least a year we give them that, so that they can call, and we're following up to make sure that they're doing okay, because some people just don't need it or don't want it, but we're there for them, and a lot of people do take advantage of it because it is tough to go through.
What happens if you really do need hospice, but you and your family and your physician, everybody agrees with that particular person, but the person does not want hospice for whatever reasons? That's a sensitive area. How do you do that?
I mean, we have a patient right now that, well, we don't, not patient, but she's actually on the home health side of things, and we've been keeping an eye on her for a while. She aligns completely up with the values of hospice, but she doesn't want to let go. But she also, sadly, she talks about, she's 92 years old or something, and she goes, I'm just, I'm ready, and but she, for some reason, is holding off on hospice, and I think it's because of what it is. I think she felt, and so it's hard. It's a very personal thing. We can only tell people the why or the benefits, and especially when we have someone who really does align up, that they should really consider it. But again, it's someone's no, I don't want it. That's we've got to respect
Mhm.
that part. A lot of times we have the run-in is the families.
I was
So
just to ask that. Yeah.
and the families are the hardest because, and I always use this scenario is that, they've got, let's say their grandma is 96 years old,
Yep.
and we're talking to the family and their grandkids that are most probably now, or their parents making the decision, and they have the same scare factor as we've been talking about previously about, I don't hospice, it's the end of life, it's
Yep.
death.
Yep.
And I look at this where you've got someone like myself, I'm give you away, I'm 50, just turned 51.
Mhm.
And when I look at my daughter who's 23, and if we talk to her about her perspective of life,
Mhm.
her perspective of life is most probably bringing the kids up,
Right.
getting them to college, going on vacations, looking at retirement, all these things that will lay
Mhm.
ahead of her because she's nice and young, right?
Yep. Yep.
And then my perspective, which is, I'm looking at sort of that retirement plan, but
Yep.
I've still got like, what am I going to do? And I'm looking to get there
Yep.
if I can with my quality.
Yep.
And then you talk to a 96-year-old person about
Mhm.
what their life is, and their life typically at that point, most people, I mean, there's some that just keep going and going, but most in that category are going to go, I'm taking every day as it comes.
Yep.
I'm thankful for every day, and I just want quality for that day.
Right.
So when we talk about hospice to someone of 24 or 40 years old,
Yeah.
that's where the scare factor, because their perspective is thinking how much I want to live forever, or I want to live
Right.
for a long time.
Right.
The 96-year-old is thinking, I want to live as long as I can, but I know I'm limited. So that's when we start looking at the hospice quality
Mhm.
and what they can get out of it, rather than what the 40-year-old person's thinking about.
Yep.
Um,
Definitely a different mindset.
Definitely. So I bring those out because I think with families, if they start thinking that way, then they start to retract on what they are looking at,
Mhm.
what's ahead of them.
Right.
And yes, it's obviously sad to lose anyone, um, but we got to know what that person really wants and what their perspective most probably is.
This is one of the services your Signature offers. Now, Signature, give me the whole title of Signature.
Uh,
Signature
it's Signature Healthcare at Home is
Healthcare.
what we are. Yeah,
That's what I want to write down.
yeah. Home health is all about rehabilitation at home.
Right.
So it's all about getting. And a lot of times someone comes from the hospital, or they've had a surgery, and they're homebound, so they have to be homebound, but
Mhm.
they're trying to get to their base level, or whatever that
Right.
is, and that's improvement. So we
Mhm.
have physiotherapists, we have speech therapists, we have nurses all going out to try and rehabilitate them and get them back. So it's almost like skilled nursing at home, but we get them back to a
Right.
level where they become more independent again. And once they get to that level, we have to discharge them.
Mhm.
So that's what home health is. And then we've got the palliative and hospice.
Okay.
We're also owned by Avamere, so they've got
Sure.
the senior living communities,
Sure.
and we have the skilled nursing facilities. So, but we work with a lot of, or I do work with a lot of the in-home care, which is more on the trying to make sure that someone's getting looked after when they're on their own, and they, helping them maybe bath, cook meals, helping them keep their houses clean, doing some shopping, um, some nursing needs and things like that. So there's home care that takes care of that. That I work with people or companies that do that, as well as trying to place uh, residents or some of our patients that, especially now, people end up leaving the hospital. They don't want to go to a skilled nursing anymore, or they don't want to go to memory care, or they don't want to go to assisted living because of COVID. But when they get home, the family realize how much of a burden, I didn't want to say burden, but how hard it is, and that they need to look at alternative. And so we also help to place people, and that's a lot of what our medical social workers will do too. So one of the things I will say, when we talk hospice again is, one thing is, quality versus treatment. So
Right,
that's a big part, because sometimes also people are getting treated, or going back to the family of wanting my mum to get treated, and they
right,
might be, if they are in there, like my mum is 84 years old, and I know if I asked her, would you want treatment, she'd most probably say no. So
right,
when we're working with especially people with dementia, we got to understand what an 84-year most probably going to say, because if they have cancer, for example, and they're having to go through chemo at 84 or 80 years old, even 70, that when we get to those ages, the trauma on their bodies is ridiculously painful and traumatic and stressful.
right,
And then what are they doing with that treatment? How is that going to affect their life? Are they going to live longer? And do they want to live longer and have,
right,
that much stress on their system, or do they
right,
want quality at that point? So
right,
those are some things, even if treatment is available, we
right,
got to look at and it's always it's the patient that needs to be asked if they possibly
right,
can, or what they would be
right.
saying at that point.
So, folks who have some form of dementia or Alzheimer's, um, do they tend to have, so when they're in that process, that transition process, do they tend to have some more behaviors that go with that? I know sometimes, for example, if they can't verbalize pain, sometimes it comes out in a behavior. Does that sometimes happen with your people with dementia who are needing hospice?
We deal with a lot of memory care patients,
Uh-huh.
because dementia is one of the number one, conditions for hospice.
Mhm.
Because it gets to a certain level that, we know there's deterioration. They stop eating, the swallowing and all those things start to
Yes,
go
yes.
downwards.
Physical signs. Yeah.
So yeah, and it is hard, because if they can't actually speak, and they can't do certain things, it's difficult to understand them. But our team is pretty good at what they do, and we, hopefully we can figure a way of communicating, I think. But yeah, that is difficult, because sometimes, they will show pain in a different way to
Exactly. Yeah.
what we're typically doing it. But we take each situation as it
Yeah.
comes.
And some of that behavior or those situations would be documented in their care plan and in their charts. For those who,
Yeah.
have to deal with day to day, that's a way of communicating the nurses to each other and
Yeah,
family.
absolutely, and especially in memory care homes, which that's typically happening. Is, we're leaving notes of what we're seeing, working with their nurse or their med aides there to just
Mhm.
understand how this person's
Yeah.
changing. What's gone on since we were last here, and a lot of times that we will rely on the staff members there, because
Yes.
they become quite connected with them, and it's like I was with a patient one time, and I couldn't understand what he was trying to say, because I can't remember what condition he had, but he
Mhm.
couldn't speak, and he was trying to communicate me. He was all there. I mean, this wasn't in memory care, but
No, no,
he was
no.
all there. But it's hard, because I don't know what he's saying, because I'm not around him.
Mhm.
But the staff members knew what he was doing and what he was
Yeah.
trying to say. So they, they get to know their habits, and so we rely a little bit on sometimes
Yeah.
their staff members.
And I see that this program, these services can come in very beneficial or very supportive for, say, a person whose family is not real involved, or where this is a difficult situation for the family as well. This gives the family the reprieve to not be involved as much. If makes them, I think, more comfortable with the situation, knowing that there are caring hospice volunteers or
Hmm.
staff that can step in and do those things that are difficult for them to do.
Yeah, I think that, when we go on when they go on hospice, I think the family, it just is a bit of more relief that they've got somebody um,
Mhm.
keeping an eye. I mean, it's not, obviously we are there. So a nurse will come in, they might be there 1 to 2 hours. Their bath aid might be the same, you know. So it's not like a substitute, but what happens, it does help
Right.
families have a bit of a relief as when we're there, but also I think they feel this support that they've got, you know, that
Exactly.
suddenly they have that they didn't have. I do have to say again, I'm more of the liaison. So I'm there to help support and coordinate the care for everybody. But I do have to say I'm not medical. So when I do have these conversations and they ask me medical advice, I'm telling them I can't, but I will try and see if we can get some information to them.
That goes to lead right into it. It's a care team. It's not just one person. You might have told us a little bit about yourself or your credentials, but you know, is there special training and different requirements to be a hospice worker, volunteer, a nurse?
Obviously, we've got nurses that obviously have to be qualified nurses, LPNs and CNAs. They also have to have a certification, and then the same with medical social workers. And there is certain certifications they can take in a hospice, and the chaplains. I think the biggest qualification is the compassion. And I think I always, you know, ask myself, you know, you wouldn't be in hospice if you didn't have compassion, because there's so many other opportunities for healthcare as a nurse. So we all have the compassion that it takes. I think I got into this part because I was doing a lot of home health and moved into the hospice because I had the compassion. I was a bit worried when I first went into hospice because I thought I'm very an emotional guy. I've got a big heart.
Yeah.
So I was worried that it was going to be too much of an emotional strain on the character I am. But as I moved into working with families, and there's some sad cases and I'm talking to them, it's, you know, the compassion's there. You get sort of pulled into the families, but I think where I thought it would be stressful and too emotional for me, I think it's the other way around. I think it's very, if I can say it, rewarding, but rewarding in a good way, that I'm able to give some help to people that really need it. And that's where I think the compassion comes in.
One of my very first jobs, I've been doing working with seniors for over 30 years, mostly in long-term care, you know, activities, social services, discharge planning, all of the whole gamut. But at Providence Benedictine, when I first started, it was just Benedictine Nursing Center, and they have a sitters program that we would arrange volunteers who would come in and sit with somebody around the clock so that the person wasn't ever alone, or at times when the families couldn't be there. And that was one of my jobs, was to coordinate that. I thought, you know, if I'm doing this program, I should actually participate as well. And I still have my own issues around death and dying, and I get very emotional. And I tried. I did it 2 different times. I gave it a good shot because it wasn't in my comfort zone, which surprised me because I'm a very compassionate person. But I get too emotional, and there's a time and a place for emotions and tears. And sure, that's a great place to share them. But sometimes when you're being the lead support person, it's not always appropriate.
Yeah, absolutely. Because when I'm talking to a family, you know, they are really trying to hold up. So I've got to be strong for them, even though sometimes I feel that feeling inside you, get quite emotional with it. But you've got to be the strong person so that they can hold up whilst you're having these hard conversations.
Right.
Yeah, you can pull yourself in. It's like, again, I had a conversation today, and he was saying, you know, I don't think I could do, and sadly, he was the one having to make these decisions on his life and whether he's doing hospice, but he was then concerned about, I don't know if I could do your job. And I'm sitting there on the other side, you know, but this is, you know, we're here to support you. It's not about me, it's about you.
So how did you get into this? You said you're not a nurse, but you started, tell us a little bit about yourself.
So I came from business background, really, and into more of the, I don't know, regular business marketing aspect of modern world, you know, sales and marketing. I was offered this position. I was working for volunteering with a charity, Liberty House, which is, and was working with Signature Healthcare at home, and worked with their ED. And so I ended up, cut a long story short, going to work for this company that was all about the compassion and relationships, and trying to work with different people. So I found a calling. I think it uses my strengths in what I do and how I build relationships with various people. And then, so I did the home health. There's a lot of home health companies, so everyone's trying to get the referral, is what they call it. And but it's very busy. But it's, healthcare. And realistically, I'm not going to deny healthcare is, hospitals, doctors, they're all about money. So it's okay to be in that environment when we're getting people better. That's what's happening. We're getting people rehabilitated, getting better, and then we move on. So I started in there to try and, build these relationships. And then, because we had hospice, I was asked, if we hired someone to do what I was doing. And then I wanted to look at doing hospice, because I felt that my wife calls it a calling. So I moved into hospice with the calling, and really work with people. And although there's a lot of hospice companies out there, my goal is to ignore the business side of it, because I just want to make sure that if I can help someone in this sort of care, that we aren't looking at competition. We aren't looking at that. If someone needs that help, I can help them. Something I think I've been waiting for a long time, because I think with all that, like I said before, it uses my strengths that I've gained in my career.
And you're obviously comfortable and very well versed and competent in your area. You know the expertise and the background. Do you have do you have a gerontology certificate or any?
No, and I hate to put it in this whole video, but my background is marketing, business. I actually do have a degree also in interior design. It's commercial interior design. So if anyone wants that, but it was a long time ago. And then I went towards actually tourism and marketing, business and marketing.
Though I must tell you, and if people don't realize that, hospice has a very big marketing component because of the topic and the sensitivity of it, and the reputation, just in general, brings up all kinds of visions and not pleasant things. It's also, you realize that it's topics that are difficult to talk about. So
absolutely.
It is a difficult thing, and you're so good at it. You're very easy to talk to, and your compassion just shows. It's great.
Well, thank you. And it's about getting the word out, is that don't be afraid of it. If things line up, don't be afraid of it. It's a good thing. It can give good care, and it can bring you that quality that you most probably might be lacking at that point.
I think the general problem is most people just always associate it with death and dying, and that's an area that none of us are totally 100% comfortable with.
And remember, if there's people, loved ones, anybody you're concerned about, or you're even yourself, if you go on it, it's not forever. You can, what we call it is, you can revoke at any possible time. So if someone's going, I'm going to try hospice because I'm a bit scared of it, but I'm going to try it. If you do it for a month and you decide, this isn't for me, I want off. You can revoke at any time. It's that easy. It's just most times people wouldn't if they need it, but but just to know that in the back of someone's mind, especially if you've got a loved one that maybe has been asked about hospice multiple times and has said no to it.
Right. Did you ever come up a situation where the patient is wanting it and the family doesn't?
Yeah, that sometimes happens. Yeah, because they're sort of wanting to, and it's hard because again, going to that person that may be just tired. I mean, and it does, age is not necessarily relative in this situation. Maybe it's the person who's been asked about hospice can make their own decisions. Their spouse is afraid to lose them, which is understandable.
Yeah.
And wants the patient or their wife, husband, to continue their treatment because they don't want to lose them. But sometimes it's, the patient themselves are tired. They're done. They're worn out. They've been doing treatment for, 10, 15 years, and they are just, I don't want to do this anymore. I mean, I had a guy that was on dialysis, and it was just, he did not want to do it anymore.
Right.
And it's, and sometimes when that happens, you've got to take what they're saying to be of value, not what you think.
Right. Well, boy, Scott, we were able to talk for an hour. That was
Wow.
no problem.
Wow, that was yeah, I thought I had a list would go through real quick,
Yeah.
but and I'm glad you're helping me, because a lot of what I do with these I do these, they're awkward conversations, and it's hard just to talk about it. And I appreciate you giving me feedback.
Well, I also, have been, like I said, in the biz long enough to know people aren't going to always know what they want to know the questions. It's such a area everybody avoids. Nobody really knows what to ask or what to say. And then as you're talking and getting into it, then something then triggers another thought or another question.
And I'm sure, Dodie, you'll put my information on, so if people have got any questions, if they're watching this,
right,
give me a call. If it's just, even if it's just, it doesn't have to go anywhere. Just if you've just got concerns, I can help you.
Do you have a business card or anything you could just hold up, Scott? Oh yeah, there it is.
Yeah. I'll speak and then.
There you go.
Oh, hang on. There we go.
There. Perfect.
Got my number on, cell number.
I also wanted to know, has COVID really affected you guys? I mean, do you have more people? I mean, COVID, the people it seems they're passing away from COVID are going pretty quickly, and they're in some kind of a isolation type area or spot. So there probably isn't that opportunity for any hospice or any support people to come in out there.
Well, what we do is, I mean, we have, so as we have hospice patients, sometimes buildings do get a case of it. We go in prepared. We do ask all our nurses, and some will volunteer that they're fine going into a COVID building. Some people don't, but we do have staff that we can still take care of them.
Okay.
But yeah, it's been a bit of a struggle to get over some of those hurdles on what's going on. But yeah, we can work pretty much with placement anywhere. So, and the hard thing is, if they've got COVID, we can't place them anywhere else because they have to do the testing, and then they have to wait a certain period of time before they can move anywhere. So yeah, we just have precautions. They gown up and make sure they got the mask and gloves and everything that they're supposed to be doing.
Have you seen a real increase with that?
No, I think it seems to be the same. I mean, there's been peaks here and there, but it doesn't seem like it's got worse or better.
So it hasn't totally affected hospice, really?
Not really. I think sometimes maybe when someone wants to put them on, might be some buildings and communities that want to have care coming in. So sometimes that restricts. And then the sad part is, if we're in a community, to be able to offer them like the massage. A lot of times they're only letting medical staff in.
Right. Scott, it's been fascinating.
Yes.
And it's been very informative. And I really appreciate you taking the time to meet me and discuss this difficult conversation. It obviously is a tough one for everybody, no matter how old you are and whatever physical state or emotional or mental state. It's not an easy thing to talk about.
No, it's not. and thank you for having me.
Thank you. I will talk to you soon.
All right. Thanks a lot. You take care.
You too. Bye-bye.
Bye.